Pulmonary rehabilitation is one intervention which is widely underused across the world and has been shown to be effectively improving the quality of life and functional capacity of patients suffering from chronic respiratory diseases. In this module, we are going to learn what this pulmonary rehabilitation is about, what are the basics and the processes which are involved in it, what is the organization and components of the rehabilitation program, indications, contraindications and settings in which it can be delivered, how to give the exercise training in this program, and duration, sessions, intensity and interval of giving exercises in the patients of rehabilitation. And of course, the program in the end would discuss what are the outcome assessments and the follow-up visits of the patient who has done successfully a complete rehabilitation program. History of pulmonary rehabilitation dates back to 1950s till the time when it was considered that giving rest to the patients with chronic respiratory diseases is doing rather more harm than doing good for them. In 1960s, Petty was the first one who had a comprehensive care program for patients with chronic airway obstruction, whereby from the rest to the activity was the motto of improving the patient's overall health status. In 1974, it was the first time when ACCP gave its definition of pulmonary rehabilitation. However, there were a lot of controversies at that point of time, and next 2 decades led to a final tuning of the definition, which came in 90s with the definitive adaptations and a newer outlook to what the pulmonary rehabilitation should mean to healthcare givers as well as to the patients. Today, we define pulmonary rehabilitation as a comprehensive intervention. The most important step to understand is that it is not only the exercise training of the patients. Exercise no doubtly produces the most important component of this rehabilitation, but it is based on a thorough assessment of the patient at the beginning of the program, and then the patient is followed by giving tailored therapies, thereby to improve the patient's education and a behavioral change. This leads to physical as well as psychological improvement of the patient who are suffering from chronic respiratory diseases, and in the end, we always want to promote a long-term adherence to health-enhancing behaviors in this group of patients. The concept of rehabilitation comes from rest to activity. That is, the patients who are suffering from chronic respiratory diseases, whereby they would like to take more rest because any amount of activity produces breathlessness, and this breathlessness produces deconditioning of the peripheral muscles as well as more disability, which leads to more rest in this group of patients. So in fact, there is a spiral of dyspnea which leads to rest and inactivity and more rest and more inactivity, and ultimately leads to worsening of dyspnea in this group of patients. Chronic lung diseases patients have got multiple factors which leads to increasing in breathlessness. There could be drugs, there could be hypoxia, there could be chronic inflammation, there could be poor nutrition along with the underlying chronic respiratory disease or the functional impairment of this group of patients. This leads to reduced activity, and reduced activity leads to social isolation of this group of patients, which leads to development of depression and feeling of more breathlessness. So patient once gets into this spiral, finally becomes deconditioned, and deconditioning per se leads to rest and more inactivity and more dyspnea. So as we discussed, that it is an intervention of its own, which requires multiple therapies, and hence it will require multiple interventions in the patient. So it will require a respiratory physician, respiratory therapist, a nutritionist, a psychologist, a counselor, exercise physiologist, and so on. And very important to realize that this is an intervention which is not to be given only once time in the life of the patient. This is a kind of a changing the behavior of the patient, and it is given at multiple times during the life of the patient with a chronic respiratory disease. So it is year after year, months after months, till the patient adapts a behavior where rest is not the answer to breathlessness and activity is the routine for a daily working of this group of patients. There have been set goals for pulmonary rehabilitation, which starts with to minimize the patient's symptom burden, to maximize their exercise performance, promote their autonomy so that they can be independent, increase their participation in day-to-day activities, improve their health-related quality of life, and of course, lead to a long-term health enhancing behavioral change in this group of patients. Why pulmonary rehabilitation is so important? Because the current evidence which suggests that it clearly leads to decrease in dyspnea, decrease in fatigue, improves the emotional function of the patient, enhances patient's sense of control over their own day-to-day activities, and it has been shown in nearly 31 RCTs where this kind of an effect in patients with chronic respiratory disease has been uniform, and the improvements are moderately large and clinically significant. The studies have shown that there is a significant reduction of breathlessness in the patients who undergo pulmonary rehabilitation program, and the leg discomfort which contributes to fatigue on activity is also significantly reduced after a successful participation in the rehabilitation program. Why is the benefits of rehabilitation on the muscle composition? If we look into it, the COPD patients or patients who have got a chronic respiratory disease, there is a significant reduction in the muscle mass, and this muscle mass leads to one particular type of muscles which are further decreased, that is type 2A, and it leads to increase in enzymes with citrate synthesis. So the patients undergo rehabilitation program by increasing the activity, which increases the muscle mass and converts the type 2B fibers to type 2A, and type 1A fibers become more rich with the mitochondria. This kind of change leads to muscles becoming more effective for daily day-to-day work when they are working, particularly the lower limb muscles, and also in the upper limb muscles it contributes to decrease in breathlessness. So when the patients undergo rehabilitation, there are lots of benefits which are achieved. This high intensity exercise program alters the muscle metabolism and allows a higher magnitude of work at the same level of dyspnea or appreciably less level of dyspnea. The peak VO2, that is VO2 max, is improved in this group of patients, and there is a reduction in dynamic hyperinflation. Thereby, it leads to desensitization of dyspnea, and in the toto or summarize, we can say that these patients are able to exercise much more with less amount of dyspnea. The ERS ATS view has been given on organization, how to organize. In practical details, the program construction and settings vary from country to country as well as from the healthcare systems which are providing it. And there is no internationally recognized formula which designs this program, because its structure just reflects the policies as well as the healthcare needs of the population as well as the country, and the funding coming thereby leading to a different kind of organization in a different kind of setups. Primarily, the organization of a pulmonary rehabilitation program starts by first getting the patients to the rehabilitation, which is the referral point. Then it goes into the selection and the screening of the patients, whether the patients are right candidates for rehabilitation or not. Once it is found that these patients are good candidates, they are sent into the rehabilitation program. Now, rehabilitation program then finally decides that what duration, where it is to be performed, and when to initiate. And once these are all done, patient starts, even after completion, the aftercare into the rehabilitation. So what it means is, even after going through the rehabilitation, the after follow-up of these patients is a must, which requires a constant activity as well as monitoring of the patients as to how much they are active after finishing the program. The process of pulmonary rehabilitation program starts by the referral from the medical specialist, and then a screening as well as the selection of the candidates into the rehabilitation center. The rehabilitation center performs certain tests and finds the suitability of the patient as well as the exercise intensity from where to start and to what level to go. And once that is started, the patient is monitored for their day-to-day progress, and mid-term progress is also evaluated by certain definitive parameters which we are going to discuss in next couple of slides. Most of the people who refer the patients are either the chest physicians or internist, and there are certain patients who are referred after their exacerbation discharged from the hospital. The assessment to the outcome is a continuum in the rehabilitation. So, as I said that to begin with, the patient is once sent to the rehabilitation program, goes through the selection and the assessment, then undergoes an exercise training, provided nutritional support, psychological support, educational and counseling, medication check, and once the patient goes through it, then there is an outcome assessment. What all has been achieved is the outcome assessment. Screening of the patient requires a very important step, that is to select the right patient. And the right patient will only get the right treatment in the right dose and in the right time, which leads to ultimate right outcome. Right outcome is very essential because rehabilitation program, if is not able to provide the right outcome assessments or the right outcome results to the patients are not going to be happy. The selection criteria has indications and contraindications. And if you look at this chart, it shows that the indication is a long list and contraindications is a very short list, which means that there is a wide group of indications for patients to be referred to pulmonary rehabilitation. Persistent respiratory symptoms like dyspnea despite medical therapy, limitation in functional status despite optimized medical therapy, impaired health related quality of life, decreased occupational performance of the patient, psychological problems which leads to underlying worsening of the respiratory illness, difficulty with medication as medical regimens, difficulty in performing day-to-day activities, nutritional depletion, increased use of medical resources, and gas change abnormalities in the patients with chronic respiratory diseases makes them fit to undergo rehabilitation. Because if these are the indications, the outcomes will be to improve them, and these outcome improvements have been shown on these particular parameters. Contraindications are unstable patients, like patients who have got unstable cardiac disease, patients who have got significant ortho or neuro problems whereby they cannot participate in the rehabilitation program, uncontrolled diabetes, psychiatric disorders where patients are not willing to participate, severe exercise induced hypoxemia which cannot be corrected with oxygen during exercise, and of course the patient's inability to participate and come to the rehabilitation center to perform the proper monitored exercise program. Just a list of conditions in which the patients are referred to the rehabilitation program. Obstructive diseases like COPD, asthma, bronchiectasis, cystic fibrosis, and bronchiolitis obliterans. Restrictive diseases like interstitial lung diseases, chest wall diseases, and neuromuscular disorders. And certain miscellaneous diseases like lung cancer before and after surgery, obesity related lung diseases, and patients who are ventilator dependent. Are there any functional criteria that is based on the pulmonary function test? Then if you look at it, we have spirometry criteria, diffusion capacity criteria, gas exchange criteria, and criteria based on the exercise testing. In the spirometry, FEV1 less than 80% with a ratio of FEV1 FVC less than 70% is an indication, which becomes a very broad criteria, which means any patient who is suffering from a chronic respiratory disease with a persistent airflow limitation is a candidate for a rehabilitation program. Diffusion capacity less than 65% of predicted, hypoxemia either at rest or induced by exercise, which is corrected by giving oxygen during exercise, are also the indications to improve the gas exchange of the patient through the rehabilitation program. Cardiopulmonary exercise testing showing that the patient has ventilatory limitation with decrease in their ventilatory achievement is again an indication to put them into rehab program. There are certain specific criteria for selecting patients for rehabilitation, like those who are undergoing lung transplantation, lung volume reduction surgeries, or patients who are undergoing lung resections. So, pre and post surgical rehabilitation is a must in this group of patients. Smokers are generally not referred to rehabilitation program, but smoking is not a contraindication for the rehab program. And it has been shown that even current smokers perform better on rehabilitation program by showing improvement in their functional capacity as well as health related quality of life. Smoking cessation is also a component of rehabilitation program. Hence, current smokers get additional benefit by coming into rehabilitation program by not only getting counseling, but also if needed pharmacotherapy as well as pharmacotherapeutic advices from the physician looking after the rehabilitation program. Can it be initiated in stable patient when they are not much impaired? That is the most common question which comes to the mind, and the answer is yes. Most of the time traditionally we wait to refer the patients till they are very sick or very dyspneic. But the indications for starting the rehabilitation program is as soon as the patient is having any of the symptoms which we have already discussed, like breathlessness, impaired quality of life, decreased functional capacity, decreased occupational performance, or lung function criteria, by which any one of them patient can be referred to the rehabilitation program. So the idea to introduce the rehabilitation program is when the patients have mild to moderate disease rather than severe to very severe disease. At this point of time, if early rehabilitation is given, then it improves the patient's exercise capacity and physical activity, promotes the self-efficacy to these patients, and of course decreases the exacerbations in this group of patients. So it should be started in early stage as soon as the disease is diagnosed. The hospitalization leads to further inactivity in this group of patients. So those patients who gets hospitalized will become inactive, and if not put into rehabilitation program and encouraged for physical activity, it predisposes to frequent hospitalizations or recurrent hospitalizations in this group of patients. The studies have shown that if patients are not put into an activity after their discharge, their chances of getting readmitted within 30 days are very high. Can it be started when the patient is still in the hospital? And there are studies which have shown that starting the rehabilitation once the patient is stable with chronic respiratory disease who has been admitted with an exacerbation of worsening is safe, effective, and it improves not only the exercise tolerance, symptoms and quality of life of the patient, but also this is the time when patients are more tuned, or rather more acceptable to be a part of the rehabilitation program. What are the components of the rehabilitation program? As I said in the beginning, the intervention is a long list and it is not only one. So besides the exercise therapy, optimal drug therapy, oxygen, smoking cessation, inspiratory muscle training, mucus evacuation, pursed lip breathing and other chest physiotherapy also becomes a part of it. Psychosocial counseling is a very essential component of the rehabilitation program to improve not only their behavior but to address the issues of anxiety as well as depression. Exacerbation self-management, nutritional supplements, hormonal supplements and home adaptation aids are also advised to this group of patients to increase their functional capacity. Energy conservation techniques and behavioral change is slowly being introduced into the rehabilitation program, so that at the end of the program, the patient is not only self-sufficient but has also got a sufficient change in his behavior, whereby he knows how to adjust his therapy and feel good by increasing his activity, or by like daily walks which are given outside, and continuing of aftercare not only into the rehabilitation but also with their chest physicians. The components in the pulmonary rehabilitation program are too many. As we have seen that all the components cannot be put into one rehabilitation program and offered to all the patients. So the answer to this is to tailor-made the therapy according to the requirements of the patient, and hence all the centers across the world make individual components choice for the patients depending upon their individual needs. If the patient's dyspnea is a predominant symptom, then all the components which are addressing the dyspnea of the patient are included into it. However, if it's the nutrition which is the most important part along with the dyspnea for the patient, nutrition becomes an important component of it. Similarly, psychosocial handling, counseling, medication, smoking cessation, oxygen, all of them will be dependent upon whether the patient needs them or not. So individually, after the screening has been done, it is the job of the rehabilitation specialist to decide what are the individual components to be chosen for the patient. Invariably, all the components are not chosen, and there is no blanket kind of a package which can be given to all patients. So hence, the team may look little bigger, starting from a physiologist which looks after the exercise part, which is the cornerstone for the rehabilitation program, also looked after by respiratory therapists, psychologists, behavioral specialists, nutritionists, occupational therapists, social workers, patient educator, and a good chest physician. But it is in reality not possible to have such a big team. So whatever is available, with that resources, from 2 to 3 to 4 number of people generally participate into the rehabilitation program, where one person invariably duals the role of 1, 2 or 3 people, thereby trying to expand the scope of pulmonary rehabilitation. Where do we do this rehabilitation? There are primarily 2 settings in which it can be done. One is an outpatient program and another is an inpatient program. So inpatient program is when the patient is already in the hospital, and it starts when the patient is admitted with the worsening of breathlessness. This not only exposes the patient to rehabilitation, but also makes them more tuned to accept this rehabilitation as one of the important steps to prevent their hospitalizations and exacerbations. This inpatient program is generally in the hospital, it is rigorous and it is the gold standard program. In the outpatient, we can also arrange such kind of programs either in the community level or at the home of the patient. But these kind of programs are very difficult, because in these situations the labor intensive area would mean that the patients will require a lot of people going to individual centers and their homes to do these kind of activities. So in the outpatient also, after the discharge, the patients would invariably come back to the hospital to complete their rehabilitation programs by coming 2 times, 3 times to 4 times a week. So it is in fact a blend of inpatient program finally getting into outpatient program, where the patient follows on a outpatient basis. Home-based programs are the one which are newly being discussed, primarily because there is a travel problem most of the times after discharge from the hospital. Patient needs to come to the hospital to do the program 2, 3 or 4 times a week, where somebody needs to bring them, and they may be living at far off distances. In such cases, after the discharge, the drop-out rate is very high. So if they carry on with this kind of a program at home is one of the options. But home-based programs are unsupervised programs. So how much activity patients are doing and how much it is effective, it is very difficult to assess. Patients will invariably say they are doing the activities, but activity charts may not actually reveal that they are doing the amount of activity which is required to be a part of the rehabilitation potential for success. There are also now technology-based assistance in these programs, whereby patients do the exercises at home and their respiratory therapist monitor it in the hospitals, either on the Skype or other social media, which is one way of cutting short the patient's visit to the hospital. As I said, the exercise is a very important point in the rehabilitation program, because exercise improves the muscle mass, and increase in muscle mass leads to increase in muscle performance, and muscle performance increase translates to improve in functional capacity and decreasing the dyspnea of the patient. So idea of exercise training is to get this patient from the spiral of deconditioning, which has been primarily induced by the myopathy of the peripheral muscles, which is not only related to the systemic inflammation, which is a component of chronic respiratory diseases, but also of the pharmacotherapeutic drugs which we have used, which includes corticosteroids. How do we program these patients into the exercise once they come to the rehab program? So the exercise is given with an aim to give right duration, in right frequency, right intensity and the right modalities. So the basic principles are, there are 2 types of exercises. One is an endurance and another is strength. In the endurance, we increase the capacity of the patient, which is most commonly required in this group of patients, because they need to walk more. If they need to walk more, they need to increase their endurance capacity. So endurance exercises are given. So modality is endurance. The other is strength, in which people would like to pick up some amount of weight, like they want to carry about 2 kg of weight and they are not able to carry that weight. So if they want that kind of strength, then there is strengthening exercise given. Most patients of chronic respiratory diseases are given both type of exercises, but certainly if such patients are very sick, then they generally start with one kind of exercise and the other kind of exercise is added as the patient improves and shows his interest into the rehabilitation program. How much load is to be given? Load is depending upon the intensity, and we need to give high intensity, and that is a major drawback in home based exercises, where patients tend to use low intensity exercises in which the benefits are minimum in comparison to high intensity exercises where the benefits are significantly more. Frequency is, it is to be done almost daily, but then at least twice a week. Less than twice a week is not effective. Duration is about 15 to 45 minutes, and generally it requires a warm up and a cool period of 5 to 10 minutes at the beginning and 5 to 10 minutes at the end of the exercise program. And very important is to patients to be informed that once they go through this program completely, it is reversible. The benefits are reversible. So they need to continue this exercise if they want to maintain the benefits which they have achieved by participating in this program. Endurance training is generally repetitive actions. One repetitive action is walking, another is to do the exercises on the treadmill, and third is to do the biking. Now biking can be done for the lower limbs as well as it is done for the arms, which is in the form of arm ergometer. So you have endurance exercises for the upper limb, endurance exercises for the lower limb. Depending upon the patient's preference, the exercise is chosen. Some people would be very happy in performing the bicycle exercises, others may be happy in walking on the treadmill. So this is an individual preference, and it has to be discussed with the patient and given both the modalities and see what the patient is comfortable with. If the patient is not comfortable with any one of them, then it is to simply start with walking on a flat ground and thereby to increase the patient's distance walked by increasing the intensity which is given during this exercise of simple like 6-minute walk test. Biking is very important component of rehabilitation program in group of patients who become hypoxic during the rehabilitation. And these are the patients who are either having severe COPD or patients with interstitial lung disease or any patient who has got a chronic long-standing respiratory diseases, because biking produces less hypoxia. So if we do a ergometer, cycle ergometer, whether we do it for the upper limb or for the lower limb, less hypoxia is produced, less oxygen supplementation is to be given. On the other hand, if treadmill is to be given, then the patient needs to be monitored more closely, and treadmill also requires a higher times of oxygen. So if the patient asks which exercise to perform at home, because most of the people have treadmill at home, we advise them not to do treadmill without supervision. It is the arm ergometer or bicycle ergometer which are much more safer for the patients who are hypoxic on exercise. However, if the patient is not hypoxic on exercise, then treadmill is a very good exercise to improve their endurance or to improve their power of endurance for performing the exercises. These are some of the exercises which are being shown, like this is an arm ergometer which is being shown, and this is the intensity of the exercise is increased till the time we find that the patient is moderately dyspneic. The end of the exercise in these situations is by the Borg scale. The other one is showing cycle ergometer where the lower limb exercises are being done. It can be performed 3 to 5 times a week, and patients are very happy in performing these exercises because they don't feel much dyspneic on this particular ergometry exercises. If we have to choose between treadmill and cycle ergometer causes less saturation, requires less amount of monitoring, and if you need to monitor, monitoring is easy because patient is not constantly running. Also, if the treadmill is given, treadmill gives to less fatigue to the patient. So if the patient is like becoming fatigued very soon, then they do better on the treadmill. And of course, because it requires walking, so lots of people are very familiar. But there is a drawback that patient can fall from a treadmill. So we need to be very careful for thin, fragile patients who are in respiratory distress and not used to walking on treadmill. They need to be given a treadmill test before showing whether they can really undergo a treadmill walk for the exercise training or not. Intensity is very important. As I said, high intensity exercises have to be given to the patient. And high intensity is when the patient is able to achieve 60% of his VO2 max. So it would require a cardiopulmonary exercise testing to find out what is the VO2 max of the patient, which is done at the time of screening and the selection of the patients. And if the CPAT is not available, then the other alternative is to do it by a 6-minute walk test, where the standard formulas exist to convert the 6-minute walk test distance into VO2 max. And all patients should be asked to exercise till the 60% of the VO2 max is done. But most of these centers find it very difficult to achieve that. So they use a simple formula, which is a Borg dyspnea scale. So patients are put with a Borg scale, and when they say that the exercise they have done to a limit between 4 to 6 on the scale of discomfort means that the patient is now performing a high intensity exercise. And to maintain at that level and not to increase further the resistance or to increase the speed of the exercises which are being given to the patient. There are certain people who would like to also include a heart rate maximum as an exercise test where to stop the patient, but this is no longer recommended. The other type of exercise, which is the strength exercises, which is primarily required to increase the capacity of the patient to lift weight, which is most commonly required in the bathroom activities as well as in the shopping areas. This is given by giving free weights to the patient, hand and ankle weights adding to the patient, and using some own body weight like squats and stair climbing. Elastic bands are there to give elastic resistance exercises. There are machine weights or simple sit and stand exercises from the chair, which are also given to this group of patients. What it does, it improves the muscle endurance and strength both. Endurance is improved if less weight is given with more repetitions, and strength is improved when higher weights are given but fewer repetitions. And obviously you have to alternate between these two because you want to improve both endurance as well as strength of the muscles to get the maximum benefit of the rehabilitation program. These are the kind of resistance exercises which are done in rhythmic manner, moderate to slow controlled speed, full range of motion is acquired, and of course the patients are asked not to breath hold or strain during these procedures and should perform a pursed lip breathing, which is taught to these patients when they are undergoing a resistance training program. Alternating between upper limb as well as lower limb body exercises for the strength is generally done so that the patient doesn't tire out and the muscles don't become sore at the end of the single day performance. How much the weight can be given to this patient is generally determined by what is called 1 RM. 1 RM is 1 repetition maximum. What it means is the maximum weight which a patient can only pick up at one point of time. So this determines that this is the maximum which a patient can do, and you need to be a little less than that if you are doing high intensity exercises, or a little more less than that if you are doing low intensity to increase the endurance of this group of patients. These are certain upper limb exercises like rotating of the upper limbs or pushing against the wall and leaning against the wall. There are certain lower limb exercises which are primarily around the chair, which are being taught to the patients, which is like walking on the spot, cough exercises, sitting to standing exercises on the chair, and strengthening of the quadriceps muscles, which is normal for the patients who have got knee joint problems. What is the way in which these exercises are given? So there are exercises we may decide for a patient that he needs to do walking, he needs to do arm ergometry, both upper limb and lower limb, and he has to do some resistive exercises like few weights on some sitting and sitting with the chair and getting up from the chair, primarily for the lower limbs. So these have to be all done in a rhythmical manner where one follows the other depending upon how tired patient becomes, and then patient has to be given adequate rest in between. But when the patients are doing endurance exercises, like when they are doing upper limb arm ergometry and lower limb ergometry, so in this manner they can undergo actually a continuous session. They can take 20 to 60 minutes if they are physically good, and in this case they do either continuous running or continuous arm ergometry or lower limb ergometry, or there can be blocks of high intensity exercises followed by rest and again another episode of high intensity exercises like it has been shown. So in the interval training you have exercise, you have rest for some time which is about 5 minutes, again an exercise for a different set of muscles, and then again a rest, and then again an exercise in a different form. So you can have a treadmill followed by rest, followed by arm ergometry, followed by rest, and followed by strengthening exercises. This would invariably take about 1.5 hours for the patient depending upon how strong he is and how much he can perform. Another important aspect when we are giving exercises to the patient and the rehabilitation is to see that they don't desaturate during exercise. So they would require oxygen supplementation during their exercise training. And it has been shown that if these patients are given oxygen during their exercise performance programs, then they do much better, because it leads to less dyspnea at the same level of exercise, which leads to patients able to perform more exercise, and it also leads to better development of health related quality of life and a higher 6-minute walk test distance in the group of patients who are trained on oxygen. So supplemental oxygen being given during rehabilitation is an important step to be considered in the group of patients who are either hypoxic at rest or do become hypoxic even slightly during the exercise. However, the Cochrane analysis has not given a clear guideline as to who are the group of patients in whom the oxygen supplementation should be given. Any patient who are mild to moderately severe or have got mild hypoxia are likely to be benefited. But those patients who are non-hypoxic, it has been shown that oxygen does relieve their dyspnea also. And if this kind of a dyspnea is less during exercise, they are likely to be benefited. So it has to be individually tailored depending upon whether the patient performs or better or not. So the basic guideline for giving oxygen is, if patient is hypoxic at rest, he needs to be given oxygen during exercise. If he becomes hypoxic during exercise, he needs to be given oxygen during exercise. And if he is non-hypoxic at rest as well as exercise, then we have to give oxygen and see whether his exercise performance improves with giving oxygen or not. If it does, it is better to give him exercise protocol with oxygen. If it makes no difference, then this patient does not require oxygen supplementation during the exercise training. In some of the programs, if there is inspiratory muscle, which is a very common component of patients with chronic respiratory diseases like COPD, then inspiratory muscle trainers are also included as a part of the rehabilitation program. These are voluntary isocapnic hyperventilation exercises, inspiratory threshold loading devices are there, or there is inspiratory resisting loading devices. So either it is by the breathing exercises or it is by the devices which are available. Inspiratory muscle training as an adjunct to whole body exercise training is given. IMT is never given alone in the rehabilitation, and it becomes an important component if at the screening it is found that patients' inspiratory muscle strengths are reduced by significant about 60 to 80%. So we do PI max, and if PI max is reduced at the beginning, then these patients are trained nearly about at 60 to 80% of whatever is their PI max, which is being performed at the initial selection of this group of patients. Generally 30 times it is done every day. During the rehabilitation program, giving them energy conservation breathing techniques is an important component. So they are taught about pursed lip breathing, which is a very important component which needs to be incorporated during their exercise training program and adopting them in their daily day-to-day activities. Diaphragmatic breathing is also an essential component of breathing exercises which are told to them, whereby they keep hands one in the chest and one in the abdomen, and they are trained how to coordinate their breathing by improving their diaphragmatic function. How long to give this rehabilitation program? And there is no consensus about it, and the general consensus is longer the program, the better it is. But yes, there is a definite minimum period, and that is 12 sessions, which involves about 4 weeks, or 20 sessions which are spread over 2 months. Factors which determine the duration is how much the patient is progressing towards achieving its goals. So even if at the end of the program patient is becoming better, they are advised to continue the program. The optimization of the benefit is a must, and that will also determine whether to continue the patient into the program or not. Generally, the outpatient programs are scheduled 2 to 3 times a week, but certainly few of the patients would like to participate, and they can be even given 5 times a week. Duration of each session is about 1 to 4 hours, and generally it is considered that programs which last more than 12 weeks are the ones which are much better than the programs which are shorter than 12 weeks. Overall, if we discuss that what is the best duration, then the answer is not there, but we know that 8 weeks is the minimum, 12 weeks is the optimum, and perhaps 20 weeks is the best. However, the best is still as long as the patient would like to continue the program, which may be months or may be continued on a year's basis and may be interrupted by few sessions which are done like once a week, and then maybe after 6 months the patient rejoins the program again at the same intensity of 2 to 3 times a week. The important issue in rehabilitation programs is not only to improve the recruitment, but also to see increased compliance of this group of patients. So what leads to these patients drop out from the rehabilitation program? Travel and location is the most important component, and hence the rehabilitation program has to be near the patient's home. Perception of the benefit is very important, and that needs to be emphasized by the chest physician, that how important is rehabilitation in his care of overall chronic respiratory condition, where pharmacotherapy has its limitations, and beyond pharmacotherapy, the non-pharmacological intervention, most importantly, is rehabilitation. Competing commitments is very important for some of the patients, where they find that they don't get time to commit, but then the time is only important for those patients who do not realize the perceived benefits which are likely to come from the rehab program. Poor understanding of the program and perception of the health status is also a very important component, which needs to be upfront confronted with the patient at the time when we screen and select the patient for the rehab program. Success in the patient's recruitment is bringing the rehab to the patient as close to as possible, where he can come and participate, motivating these patients and explaining the potential of the rehab on each and every visit till the time patient finally becomes a partner to the rehab program. Reversibility after exercise training is very important to remember. We should not consider that once the patient has been given rehabilitation, the benefit will last ever. It has been shown that within 6 months to 12 months of leaving the rehabilitation program, patients come back to their zero level from where the rehabilitation program was seen. So all the achievements which are done after the rehabilitation program over a year of time, they are lost unless and until the patients continue some kind of activity, or once a week or once in 2 weeks continue to be a part of the rehabilitation program. So maintenance training in the rehabilitation is very important. This has to be taken care of once the patient comes after successful rehabilitation into follow-up visits with the chest physician. So again, it becomes a duty to tell them that these kind of high intensity exercises, even if they are done once a week or once in 2 weeks, are required in the maintenance phase of their rehabilitation program, and the maintenance phase is for the rest of the life of the patients. Safety is one of the issues which are discussed in the rehabilitation program, and in the large surveys it has been shown that by and large it is very safe. Generally, the patients underwent a cardiopulmonary exercise testing in the West prior to being inducted into the rehabilitation program, and whatever are the complications, they primarily occur in the CPAT labs, which includes infarctions and serious arrhythmias, but overall complication rates even in the CPAT exercise labs is very, very rare. But the important safety point in the rehabilitation is the desaturation, and nearly the desaturation occurs more important in patients with COPD and interstitial lung diseases, but then it is much less in patients who undergo cycle ergometry. So those patients who are hypoxic should be safely first trained on ergometers, bicycle ergometers, before being putting on to the treadmill exercises. Once the patients are going through this program, it is always worthwhile to look at the back and see what the patients are achieving, and if they are not achieving, to modify the program in between. But definitely at the end of the day, once the patients go through this program, an outcome assessment is to be done, that what have we achieved in this rehabilitation program. And this assessment can be, as I said, in the real time, that is done during the visits of the patient, maybe after 4 visits, after 8 visits, after 12 visits, or it is done at the end of the program. At the end of the program, it is basically mostly based on the recall, and parameters to be assessed are quality of life, dyspnea indices, as well as the functional status of the patient. We do not look into the improvement in the lung functions in this group of patients, because rehabilitation has not been shown to significantly improve the lung function, but it has been shown to significantly improve the dyspnea indices, quality of life of the patients, and functional status of these patients. And most important hardcore fact is that if you perform a 6-minute walk test at the end of the program and compare it with the values of the program of the 6-minute walk test which was done at the beginning of the program, there is a significant improvement. And this threshold of clinical significant change which is required for the success of the rehab program, which is to be translated to the benefits by the patient, is improvement in walk distance by 86 meters. Although the outcome assessments will also vary according to what were the goals which were required by the patient. So hence we note down the goals of the program at the beginning depending upon the patient's desires. What do they achieve will depend upon what do they wanted to achieve from the beginning of the program. Hence the outcome assessments are different for different patients, and it has to be individualized. Nutritional support is also an important component of the rehabilitation program, because once they go through the exercises, muscle building is must. We are doing the exercises, but if the nutritional supplement is not available to the muscles, then the improvement in the muscle strength will not be optimized. So there is a nutritional assessment done, which is subjective assessment, as well as assessment of BMI, which is basic, also recommended by NCCP and ICS guideline for all patients undergoing rehabilitation, and caloric supplementation is needed to meet the demands of the increased energy which is required in the patients participating in the exercise. So we need to provide them with adequate carbohydrates, proteins, with a BMI of patients having less than 21 or loss of more than 10% of body weight in the past 6 months. So these are the group of patients which are again screened and targeted at the beginning, that these patients at the end of the program will need to improve their weight as well as the protein component, and these are generally tested at the outcomes also for this group of patients. Psychological support is also a very important part of the rehabilitation program, because depression and anxiety individually are seen in about 40% of patients of COPD who finally end up into the rehabilitation program. And as the patient of COPDs suffer more and more, the depression becomes more and more common. Psychotherapy or psychosocial support not only improves the symptoms of anxiety and depression, but overall functional status of this group of patients. So psychological interventions not only require the disability evaluation, continued education sessions are required for these patients and also for their family members. And in select group of patients, even pharmacotherapy may be used as an adjunct in this group of patients who are severely depressed or very anxious from their underlying disease, where the psychosocial counseling has not helped them much. So just to conclude, whatever has been discussed and learned is that the PR is an intervention which has got many components and is not limited to simple exercise training. And it is although we realize the exercise training is a backbone of the program, but we need to use all the components of rehabilitation program depending upon the individual needs of the patient. This is not to be given at one time, it is given at multiple times in the life trajectory of the patient. So patients may take the rehabilitation program year after year for set durations or continue on a long-term basis for years. Once these patients come for the exercise training program, they are given both training for endurance as well as strength, which is thereby to improve overall functional capacity of the patient, not only to walk more with less dyspnea, but also able to lift some of the routine weights like 2 to 4 kg, which they may require in their daily-to-daily activities. Exercise trainings are given about 2 to 5 sessions per week, and as I said, total duration required is minimum of 8 weeks, optimal of 12 weeks, and good one or very good one is generally 20 weeks, but as long as the patient would like to continue is the best one. Supplemental oxygen is given to the patients who are hypoxic at rest or during exercise, and nutritional, psychological support and counseling and medication compliance are all checked for this group of patients from time to time to see that whatever are the components which we have included into the program are finally producing their beneficial effects in the patient or not. So even after completion of the program, patient still continues to be a part of the rehabilitation system, where even if he comes once a month or once in 2 months and visits and perform that high intensity exercises, are going to lead to long-term benefits in this group of patients. It's not only limited to COPD or interstitial lung disease. By and now we know that those patients who are undergoing lung transplantation, lung resections and lung volume reduction surgeries are also the candidates who have to undergo intensive rehabilitation prior to surgery as well as intensive rehabilitation after the surgery. So the indications for rehabilitation are ever expanding, and virtually any chronic respiratory disease patient who has symptoms despite pharmacotherapy is a candidate for joining the rehabilitation program. Thank you.